Okay, so first we're going to talk about how cancer affects the patient before we even start doing treatment. Because a lot of times, you kind of have in your mind things that you expect to be seeing with patients once they start treatment, once they start chemotherapy or surgery or radiation. But I just want to touch on some of the things that patients are going to present with before we even know that they have cancer, and when they're in the diagnostic process, before we even start treating them and doing what we need to do for them. Because cancer can impair the immune and hematopoietic function. So merely by virtue of the fact that you have cancer, you have a tumor somewhere in your body, your immune system and your hematopoietic function is going to be affected. What is hematopoietic function? Right, the cells that create blood cells. So that would be your bone marrow. So oftentimes cancers will affect the bone marrow. So patients will present with you already immunocompromised with lowered white blood cells. They'll present with you already anemic because of their reduced red blood cell count. They're gonna present with risks for bleeding because of thrombocytopenia, low platelets. So all of these are going to be just starting off on that patient before we even start giving them chemo, which is going to also affect the function of the bone marrow. How is cancer and how can cancer affect the GI structure or the function? Right, so if there's a tumor actually pressing and obstructing the GI function, what else? It can cause perforation of the bowels and leakage of bowel contents into the peritoneum. But another weird thing, just a wonderful thing that cancer can do, it can increase your metabolic rate. Because what cancer will do is will suck all the nutrients that you take in to feed itself. So you could be eating normally, exercising normally, and all of a sudden you're having this significant weight loss. And oftentimes that's the first thing that the patient goes to see the doctor about. I don't understand it, doctor. I'm eating the same, I'm exercising the same, but I'm losing weight. I've lost 20 pounds in the last month. Because the tumor that patient has is taking all those nutrients that he's ingesting, and instead of using it to maintain his own body, it's sucking it to maintain its own growth, the cancer's growth. So patients will show that they have a loss of their of weight, unexplained weight loss. What other ways can GI structure or function be affected? What? How about liver function? If you have cancers that have metastasized to the liver or liver cancers, primary liver cancers, liver function tests are going to be elevated. So you may see elevated ammonia levels. Taste changes based on the location of the cancer. How can cancer affect motor and sensory function? Right. If you have a brain tumor, it could be it's pressing on vital areas of the brain. It's affecting your motor, your sensation, your pituitary. How else can it affect sensation and motor ability? Where else could you have a tumor that would affect that? In the spinal cord. So if you have a tumor that's pressing on the spinal cord, it's going to affect the spinal nerves that are coming out of the cord. And how is cancer going to affect your respiratory function? Right, if there's a tumor in the lung, it's going to affect your ability to perfuse. It can cause a rapid respiratory rate for compensation. It can compress areas of the lung. It can damage the alveolar membrane and reduce levels of surfactant. So all of these patients can be presenting with before you even have the diagnosis and the treatment on board. So the first way that we talk about that we treat cancer is surgery. So what are the reasons? What are some of the uses of surgery as it relates to cancer treatment? Remove it. So for cure. Debulking it for palliative purposes. What else? to do a biopsy to determine if it's benign or malignant. Surgery can also be used as a prophylaxis. In what situation would surgery be done as prophylaxis? Sarah? Right. A woman who has a very strong family history of ovarian cancer may elect to have her perfectly healthy ovaries removed so she doesn't get ovarian cancer. Same thing with women who have a very high incidence of breast cancer. Will have mastectomies so that they don't develop cancer of the breast. Yes? What they usually do is in order to, to validate your necessity, what usually happens is you have to go through, the various mammograms and maybe biopsies. You had to have had a lump that they had to biopsy. I think most insurance companies are being more preventive in that area because the treatment, the cost versus what it would cost you to treat somebody who's probably got a 99.9% chance of getting breast cancer because of family history, personal history. So many women now are being offered that as an option. There's different types of surgical procedures that we use with surgery and when we treat cancer. We can have local excisions where we just remove the mass and the surrounding tissue. So that would be the patient with a lumpectomy. Or we could have wide or radical, or what they call en bloc, ENBLOC, where they take not only the tumor, but they go for the surrounding structures, the lymph nodes, other tissues, to get a wide area of excision for that patient, for that type of tumor where they feel that there is a very high risk of it having metastasized and spread. What are some of the side effects of surgery, other than the ones that you learned in 110 about the general side effects that you always assess patients for? What's unique about cancer surgeries that we would look at and that we would be concerned about with our patient? Body image. So a lot of psychosocial issues. Anxiety, very high anxiety levels. Because oftentimes, you watch it on TV and they do a biopsy and, 30 minutes later you've got the results. That's not real life. Many people have to wait 1, 2, 3 weeks or more for the results of their biopsy. So, you're just kind of waiting there with the sword hanging over your head, waiting for the other shoe to drop, and waiting for those results. Yes? Absolutely. Why are they at a high risk for sepsis? Right. Cancer patients have are immunocompromised, so they are at risk for developing sepsis more intensely and more, a much higher risk than your average surgical patient without that as a complicating factor. So your nursing care is going to be focusing, as it relates to surgery, not only on the physical needs of a patient who's just had surgery, but also the psychosocial, the body image, the anxiety, the fear, the waiting, the loss of function that's related to surgical surgeries, cancer surgeries. Radiation. So what does radiation do? It can shrink the tumor. What radiation does, the purpose of radiation is to basically interrupt the cell's ability to multiply. Because you learned in 200 where cancer cells divide more rapidly than normal cells. They don't have that natural cell death, that shut off, apoptosis that stops it from all that division and expanding. So what radiation will do is to destroy the cancer cells, with the goal being with minimal damage to the surrounding normal healthy cells. Usually ionizing radiation. And what will happen is that the cells will either die or they will be rendered unable to divide and multiply and become bigger. Now there's two types of radiation therapy that patients can have. External, or what Ignatovic referred to as teletherapy, or brachytherapy. So external therapy is what you think of with radiation, radiation therapy for that patient, where an external radiation X-ray machine pinpoints the area of the tumor and zaps it with usually gamma rays. Brachytherapy is where the radiation source is implanted or placed into the patient, either intravenously or in solid form into or nearby that tumor. They can be pellets because you have, when it comes to brachytherapy, you have two different types. You have sealed and you have unsealed. So the sealed brachytherapy would be things like the needles and the pellets and the seeds that are implanted into the area where the tumor is, or actually directly into the tumor if they can do that, versus the unsealed, which is usually given orally or intravenously or instilled into the body part like a bladder, flushing the bladder with radiation. And the way you deal with this type of therapy between the sealed and the unsealed is very different in terms of your interactions with the patients. How many of you are in the Tuesday evening clinical? So have you encountered any patients that have like the big signs across their doors, and or any patients that you've been able to take care of? Haven't had? So what they'll usually do, if you have sealed brachytherapy, you have needles or seeds or things implanted into you, you will emit radiation. Your patient will emit radiation. So they will be radioactive. Their blood and their body fluids and their urine and their stool are not necessarily going to be radioactive. So this patient needs to be in a private room. You need to limit visitors. No pregnant women or children under the age of 16 should be in contact with that patient who has sealed radiation, because they will emit that radioactivity. If they have unsealed, where they've received the radioactive isotope via an oral ingestion or an intravenous, or where it's gone into their bladder, in that case, because it's going to be excreted through the kidneys or the bowels, then their urine and their feces are going to be radioactive. And the patient themselves might emit a small amount of radiation, but your biggest concern is going to be the urine and the feces. So double, triple flushing the toilet to make sure that it's diluted and it goes down through the plumbing and nothing is left to possibly contaminate anybody that's coming into the room. Yes? Probably very mildly. You know, I mean, if it's a lot of saliva, you know, if they've got a really productive cough, yeah, but just you know, minor droplets, probably not an issue. Yeah, Kelly. There would be special containers to dispose of any kind of soiled linens and that sort of thing, because it has to be handled differently. What's that? Oh, to go into the patient that has the unsealed? And everything, just so you're only one time in. To see how much. And then we have the concepts of exposure versus dose when it comes to radiation. Exposure is defined as the amount of radiation that's being delivered to the patient, either through that external X-ray machine or through the seeds or needles or other implanted substances. The dose is the actual amount of the radiation that's being absorbed by the patient. So the exposure can be one level and the one amount, but the dose is going to be how much of that amount is actually going to be absorbed and used by that patient. And the dose is going to be affected by things like the intensity of the exposure, so the strength of the radioactive material that the patient is exposed to, the duration of the exposure. Is it through that external where you're zapping them for, you know, a few minutes and then they come back a week later, or are they actually having it implanted so it's a continuous exposure? And also the proximity or the closeness of the source. Patients are going to absorb more of the radiation the closer the radiation is to their body. So the implanted sealed radiation is the most efficient way of getting at the tumor without damaging the surrounding normal tissues. So who's aware of what the, okay, come on, move on, side effects are of patients with, yes, Veronica. So it affected his taste because he was probably irradiated in that it was a head and neck. So depending, what's that? In his throat. So depending on where the radiation is being applied, based on where your tumor is, various areas of your body. So if it's a head and neck cancer or a lung cancer, patients are going to have issues with taste. They may actually have esophageal erosion, damage to the mucosa, inflammatory responses. They can have local skin changes like rashes or burns from external therapies. Let me see what else. And many patients that are undergoing radiation will be very fatigued. Radiation tends to boost the metabolism, and patients become very fatigued when they're undergoing radiation therapy. So our general nursing care with patients is going to be trying to give palliative interventions for some of those, dry mouth, xerostomia, altered taste, teaching them how to take care of their skin when there's radiation burns on their skin. And unless the doctor has prescribed a specific cream or ointment, you should tell your patients do not put any kind of lotions or anything on your radiation burns. Just keep them clean and dry. And they should avoid being out in the sun, because that will intensify those reactions. And another problem we're going to have with radiation therapy is pathologic fractures, because bones that are exposed to radiation are more prone to fracture. And what's the definition of a pathologic fracture? Right, it's a bone that the bone breaks because it's weakened by disease, not because of trauma. So patients can have pathologic fractures and they've done absolutely nothing to cause any kind of a traumatic break, not even a fall or anything like that. And so any questions about surgery and radiation? Okay, the next we're going to talk about is chemotherapy. So, what is chemotherapy? What's the definition of chemotherapy? Treating cancer with chemicals. There's all different types of chemotherapeutic agents. Your immune ATI has a lot of different drugs and categories. I will not be testing you on the specific types and categories of chemotherapeutic agents. Is this an alkylating? Is this a this? Not going to know that. What we need to know are the general side effects and things that we're going to be encountering with patients that are on chemotherapy. We're going to talk about some specifics for some of the specific types of chemotherapies, and what we're going to be doing for those patients and treating them when they're on chemotherapy. Can anybody tell me, I know you guys didn't do any of the reading because you had the exam today, the difference between neoadjuvant and adjuvant when it relates to chemotherapy? Okay, when we use chemotherapy and we use it with surgery or radiation pre-op, that is called neoadjuvant. So before we go in to do the surgery, before we do the radiation, we will treat, oftentimes we'll use chemotherapy with both of those or one or both of those approaches prior to actually going in to do the surgery to remove the tumor. So the chemo is given to shrink the tumor to a point where it's more easily removed. Chemo, radiation, or chemo prior to surgery. Then adjuvant is where we use chemotherapy after the surgery to kill off any remaining cancer cells. So we've gone in, we've removed the lung tumor, we think we've got it all, but there's always that worry of some microscopic cancer cells that we didn't get. Then the adjuvant therapy, chemotherapy, is post-op to eradicate any leftover cells. And our goals of chemotherapy are either to cure, to increase survival time, or for palliation. And when it comes to the point where we're using chemo for palliation, then the patient and the physician are going to have a long discussion as to risks and benefits and side effects and, how much of this do I want to go through? Is it really going to help me? Is it really going to improve my quality of life, or is it going to worsen my quality of life? When we talk about chemo, we talk about the concepts of cell kill and cell cycle, and the fact that cancer cells need to be hit at various points in that cell cycle of dividing and in those rapid divisions of cells. So we have to repeat doses of chemotherapy. We need to combine chemotherapies oftentimes. We have to give time for the patient's own immune system to kind of catch up with and maybe start fighting the cancer cells on its own. So the timing and the scheduling and the whole process of chemotherapy is very strictly prescribed based on the type of chemo and the type of tumor. Body surface area, again, I think we talked about body surface area way back, right? When we talked about cardiac index. Again, one of those math questions I will not ask you to do. But chemotherapy is ordered based on the patient's body surface area. Because they're such toxic medications, we need to titrate them and control them very, very tightly so we don't overdose the patient and cause worse side effects than we are in terms of the positive results. Usually our chemotherapy is given intravenously, and the ideal is to give it through a large vein because most chemotherapeutic agents are extremely toxic, caustic. They're called vesicants because they irritate the skin. We can also administer chemo intrathecally. Which type of cancers did we talk about for intrathecal administration? Brain tumors. We can put them into a cavity, intracavity, so into the peritoneum if the patient has a lot of cancer metastasis within the peritoneum or in the bladder. Now, what we have, again, because chemotherapies are so toxic and so irritating, we have problems if they infiltrate or extravasate, where they're leaking chemotherapy into the tissues. So what do you think we should do if that happens? Stop the infusion immediately. And you leave the needle in there. You leave the IV catheter in there and you attempt to withdraw as much of that chemotherapy that leaked into the tissue as you possibly can. And then remove the IV catheter. And then depending on the type of chemotherapy, some of them will require a cold pack. Some will ask you to put a warm pack. So you would have to, whatever the protocol is for the particular agent that you're using. But anytime you infiltrate with a chemotherapeutic agent, stop the infusion immediately, leave the needle in, and aspirate as much of the agent that is leaked into the tissue as you can. And another issue with chemotherapy that you have to be that in terms of precautions when you as the nurse are administering them is if you yourself are exposed to the chemotherapeutic agents, because many of them can be absorbed into your skin, which is why nurses will usually wear protective equipment when they are administering chemotherapy. So what are the general side effects of chemotherapy? What do we expect to see in terms of GI? Nausea and vomiting. What else? Diarrhea. Loss of appetite. Stomatitis. Because chemotherapeutic agents are geared to attack rapidly dividing cells. And there's a lot of different rapidly dividing cells that are normally rapidly dividing in our bodies. So not only is the chemo going to go after that tumor that is rapidly dividing, but it's going to go after things like your GI mucosa, like your bone marrow. So patients are going to get thrombocytopenia. What is that? Platelets, reduced platelets. So a medication called Numega, N-E-U-M-E-G-A, can be given to that patient to boost the production of platelets. What's that? No, that is not Neupogen. It is Numega. Neumega. We'll talk about Neupogen in a minute. Patients, what's that? It boosts platelet production in that patient with thrombocytopenia. Patients with anemia as a result of their chemotherapy are going to be given a medication called Procrit. Anybody given Procrit? Pro in favor of, crit, hematocrit. So that's going to help to boost their red blood cell production. And then you can give them Neupogen if they have a drop in their white blood cell count, if patients are neutropenic. Neupogen, Neupogen. If a patient has a neutrophil count less than 550, they are considered neutropenic. So what do we do for that patient who is neutropenic? What are some of the precautions? Reverse isolation, washing hands. No fresh fruit or vegetables or flowers in the room. Ah, because they're all enclosed. But anything else, right? Too much bacteria. Right. So you're limiting, and usually, limiting, no kids for visitors because kids are a hotbed of germs. No offense, young man. But they do. They're just walking germ factories when they're young there. Okay, reproductive. Those are your ovaries and the testicles contain rapidly dividing cells. So chemotherapy can often affect egg production, sperm production. Alopecia, which is hair loss. Changes in the skin, anxiety, sleep disturbances, a lot of general side effects of chemotherapy, all of which you're probably familiar just from general knowledge, knowing people that have been on chemo, people that, patients that you've taken care of. Now, I know Michelle talked about bone marrow and stem cell transplants in 200. This is just a very quick review of that because there might be a couple of questions on the NLN final, so I kind of like to review it a little bit. The sources of stem cells, you learned about autologous, which is when you donate your own stem cells, right? Syngeneic, the identical twin, starting to ring bells. Yeah. Allogeneic, a matched relative, usually a sibling, or an unrelated matched donor. So basically what happens is that the stem cells or the bone marrow are infused and you have the graft versus tumor effect. The graft kills the tumor. The cells, the good cells, the transplanted cells, kill any remaining malignant cells. So what will happen is the patient will go through conditioning, several days of radiation, chemo, just basically wipe out their immune system. And then they wait a couple of days for all that chemo to clear the body, and then they infuse either the bone marrow or the stem cells. And then engraftment is when the bone marrow or the stem cells travel to where they're supposed to go and start producing new healthy blood cells and a new healthy immune system. The complications that can happen, instead of graft versus tumor effect, which is the good thing that these transplants do, we can have graft versus host. And that's the opposite of rejection. This is a situation where you have an immunocompetent graft, either the bone marrow or the stem cells, attacking the immunocompromised body system of the recipient. So what you've just given that patient is now trying to kill them because it's acting as it's an intact immune system, it's an active immune system, and instead of having the benefit of killing off the tumor, it actually attacks some of the healthy cells and organs of that patient. So we have to give the patient immunosuppressants to kind of ratchet down the activity of that bone marrow or a stem cell transplant that we gave them, but we don't want to get it down too low because then it's not going to have the positive effect that we wanted it to have, which was to kill off the cancer and build a new healthy immune system. So patients can have rashes, they can have liver issues, elevated liver functions, jaundice. All of those are going to be indications that the graft, the stem cells or the bone marrow, are not helping the patient by killing off the tumor. They're harming the patient by attacking their own healthy organs. Patients can also have what is called veno-occlusive disease, where the graft actually attaches the hepatic blood vessels. It attacks. It attacks, I'm sorry. It attacks the hepatic blood vessels. So now the liver is not getting good circulation, and patient will go into liver failure. No, that's one of the areas that the graft is going to attack. It's going to attack the liver. Right. There's a couple of other types of chemotherapeutic agents, general categories. Biological response modifiers that boost the patient's own immune system, and interferons are the most common biological response modifiers. What's that? I don't know the, I'm not sure. I'm not sure of the exact names. But it boosts the patient's immune system to fight off the cancer with that interferon. Gene therapy, which are targeted therapies where patients oftentimes can have a biopsy of the tumor. They can analyze the genetic makeup of the tumor and create a medication, a chemotherapeutic agent that will directly attack the genetic makeup of that specific tumor. So it's basically designer chemotherapy. Hormones can be used in certain types of cancers because certain types of cancers grow better in the presence of certain hormones. Like many breast cancers thrive in the presence of estrogen. So we're going to give anti-estrogen medications to women who have those types of tumors, either androgens or other types of anti-estrogen chemotherapeutic agents. Now, if we give androgens to women, what's going to happen? You're going to have abnormal hair growth. What else? Deepened voice, acne, muscle tone. Well, it depends on how the level of the androgens that we're giving them. Now, many prostate cancers thrive in the presence of testosterone. So with many men with prostate cancer are given female hormones to counteract that and stop the growth of that prostate tumor. So what happens when we give female hormones to men? With credit cards. They get gynecomastia, moobs. And anytime you give hormones to anybody, what's a big risk factor that we've talked about all semester? Clots, blood clots, DVTs. So your patient on hormonal manipulation for their cancer is at an increased risk for blood clots. And remember, we said actually even having a malignancy increases your risk of blood clots. So these patients that are very high risk for developing DVTs. Let's take a 5-minute break, and then we will talk about oncologic emergencies, and then we will be done.